What happens if the country's intensive care units are swamped with Covid-19 cases? Who or what will decide which patients get priority? Well, that is exactly what a group of doctors and ethics specialists and lay representatives are drawing up right now, those guidelines. A Health Ministry audit shows there are currently 153 intensive care beds in public hospitals, and that could be expanded to just over 560 by co-opting space from other units. The DHBs have access to about 520 ventilators. Dr. Andrew Stapleton is the spokesperson for the Australia-New Zealand Intensive Care Society Covid-19 group. I asked him if that's enough.
What we have to bear in mind is these beds aren't empty and waiting for patients to get COVID. They are 80 to 90% full at all times. So in truth, the amount of spare available beds is low. If people don't follow the rules, if the disease does spread and we get a cohort or a group of patients all coming through at once, we will very quickly exhaust that ICU capacity.
Do those beds, are there specialist staff? I know they're talking about expanding the number of ICU beds, but do those beds get tended to by specific specialised staff, and do we have those staff?
So we've got enough beds. We've got enough staff for all the beds that we've got. Once we start expanding beyond our normal numbers, we have to change the way we provide care. Fortunately, if you can call it that, when we stop, or now we've stopped doing most elective surgery, we've freed up a whole load of staff who are used to dealing with unconscious patients in the operating theatre or perhaps in the recovery room. They're not ICU nurses, but they can look after patients safely who are asleep, as ICU patients often are, and they can do that under the direct supervision of an ICU nurse, and I believe that is safe, yes.
What do we know about the demand seen in other countries for ICU beds, and where might we sit?
We have a great advantage in New Zealand because other people have had it so hard. Countries who didn't know this was coming, or countries who have taken a different approach to us, have been overwhelmed very quickly in the ICU, and we are doing everything we can, or the Prime Minister is helping us to do everything we can to avoid that scenario because it's very unpleasant indeed.
You would, I am assuming, have seen the study that came out of London that was saying about 4.5% of those infected with COVID-19 would need hospital care, and they were estimating 30% of those people may need or would need ICU care involving some kind of assistance breathing. Could we cope with that level?
There's lots of the statistics from different countries are quite different, but even if you take a best case scenario, which is probably from the Chinese data, the answer is that if we get more than 3,000 or 4,000 patients in New Zealand at the same time or within the same 2 to 3 week period, that is going to overwhelm our current ICU capacity.
And what does overwhelmed look like? What do you do then?
Well, we make beds throughout the hospital. We change our staffing. We use staff who are not used to looking after ICU patients, and we have to begin to triage patients as they come through the doors, which no one wants to do.
So the other thing this audit shows us is the availability of ventilators. It says potentially they could gather around 520. How does that compare to other countries that would be like us in terms of health systems?
Well, the 520 includes repurposing anaesthetic machines, which have ventilators built into them, which are perfectly appropriate, and then we can match the number of beds we have to the number of ventilators we have. It's true that overall we have towards the lower end in the OECD of ventilators per 100,000 of population, which doesn't help in this situation, but which is appropriate for the way we use ICU on a day-to-day basis.
If you repurpose anaesthetic ventilators, that means no operations then, though, doesn't it?
We wouldn't repurpose them all. We always have to be able to do emergency surgeries. Those things don't go away. We would just have to decide where that balance lay.
And when resources do get tight, who decides who should get access to what we have? And what will the criteria be?
So there will be criteria. Well, the criteria are complicated. They're worked out. They're being worked out, in fact, by a committee of ethicists and intensive care specialists and infectious disease specialists, as well as a lay person representative and Maori representative, a gender-balanced group. And we're working on a triage tool which will assist physicians at every hospital make a decision. And for the hard decisions, it won't just be one doctor making the decision. It'll be a group of 2 or 3 using all the information and their expertise at their fingertips.
So this committee is currently working through the guidelines?
Yes, that's correct.
And how far through are you?
Very nearly complete. Ideally, we'd like to have the triage tool and these guidelines ready by the end of this week.
What can you tell us about what the guidelines or recommendations are?
I'm not really prepared to do that before they're socialised amongst the medical community, and the Ministry of Health also needs to see them, and they are involved, but they need to sign off on them, I suppose.
Understand you don't want to give us the detail, but can you give us a broad spectrum? So will you be considering the age of the patient and existing medical conditions when deciding who should get access?
It's a lot wider than that. In fact, we'll be considering the ethical considerations, equity. We'll be considering things that we know lead to poorer outcome. We'll be considering how difficult and resource-intensive it is to look after a particular patient. Most importantly, which I should have said first, we'll be considering the patient's wishes and those of their family.
But in essence, what you are putting together is a list that will prioritise patients if we get to the point where there is not enough resource for everyone.
Yes, I think you would agree. It would be remiss of us not to do so.
So who will that go to be signed off finally?
So it's a shared responsibility between the mainly ANZICS, that's the Australian New Zealand Intensive Care Society group, and the Ministry of Health. And the tool itself is only a tool. It just produces a ranking. It's not deciding, a machine is not deciding, or a tool is not deciding who lives and who dies. That decision will always be made by a doctor or 3 at the site where the patients are.
So ultimately the buck will stop with the physicians who are on site, but this is what, a tool to begin the process for them in making that decision?
Yep, that's exactly right.
That is a lot of responsibility, isn't it?
Yes, and that is why we hope we never get to that position, and why we continue to reinforce the message to those New Zealanders who may think that this is overblown or exaggerated. It really isn't. Please follow the guidelines that have been set out by the Prime Minister.
So to those people who are wandering around today with no purpose, are not essential services and shouldn't be outside, talk to them directly now.
Well, what infuriates me about that behaviour is that it's not them that they're putting at risk, because they're probably young and well, and when they spread the virus, it won't be them that are most affected by it. But it might be their parents or their grandparents, so they should really think twice.
That's Dr. Andrew Stapleton.